Good afternoon, everybody. So I don't know if it's more worrying the presentation of the words said by Roger before in terms of quality and therefore choosing the right words. So engrading brain ultrasound. It's a very important task. I'm 100% sure we facing the beginning of giving good guidelines to colleagues. But although we have many potential problems in finalizing that, so go directly in the real world. We may be in the unit asked to perform an ultrasound because there is a mildly encephalopathic baby. We suspect sepsis, and we do the ultrasound before doing the MRI, doing the lumbar puncture, and we do see the abnormalities ultrasound that was followed by the LP and corroborated by that. So this is the real life of the very strong clinical question about a baby that is unwell, and we're using neuroimaging. But we facing a different kind of use of the neuroimaging. We're using neuroimaging for extreme preterm, for term babies symptomatic, and we coming sometimes in the different parts of the world from different specialization. I mean, in Europe, the majority of people performing ultrasound are doctors and neonatologists. In other parts of the world are sonographer or even a neuroradiologist. And we thank people like, you see, Linda and Paul Govar, who gave us a lot of culture on the subject, writing excellent books. But I still remember the glamour of this book showing fantastic ultrasound scan many years ago with a new machine available in US at that time. So what we may face is that kind of difficulties in answering a clinical question like for that baby, and you see the ultrasound, vague abnormal echogenicity on MR, but we strongly suspected he had a stroke. We waited a few days, and I start to compare ultrasound with MR. You see the signs on MR very clearly, and also going into more predictive signs of later problems on diffusion. You could see the ipsilateral hemipons, the biliary degeneration following a few days after the stroke. And so this is something that some neuroimaging can't give us, like ultrasound. And if we wish to go even in more difficult task, like grading echogenicity, I think this is very, very difficult. And we all know that if we have an asphyxiated baby, we hardly nowadays perform an ultrasound unless we wish to exclude something. But if we observe that, another problem is when we perform neuroimaging. And you do see a very severe asphyxiated baby with a normal ultrasound on day 1 and day 12, very abnormal finding the basal ganglia at least. Is this useful? I mean, I really appreciate some thoughtful consideration about where we are, where we work. And I think we should thank a lot people like Kellyton, who perform with the echogenicity sort of score criteria with normality, score number 1, score number 2, and score number 3 for the most severe forms of encephalopathy of newborns baby. And the setting was in Uganda, and so that technique, the ultrasound that we hardly give too much attention for asphyxia, was extremely useful to highlight that very early you could see lesion due to the asphyxia into the brain. There are a few centers in the world that are investing on ultrasound and asphyxia, and mainly they're trying to give us evidence that a ratio between gray matter and white matter may be helpful in predicting things. But again, you have to compare with something more sensitive on that kind of disease, like MRI. And this is, I think, is the leitmotif of the talk, in the sense that we're speaking about ultrasound nowadays, but we can't forget that we have as well MRI. And this is my pioneer slide showing which kind of bias we may have had at that time making diagnosis, but we were trying to make diagnosis like in this baby. This was in 1899, in which we performed MRI as well, 0.5 Tesla. But again, having even trustable thought, what does it mean, echogenicity, I think is extremely difficult. What it may disclose, in this case, it may disclose a reduction potentially in echogenicity, but we have something else to think about. And we could observe that kind of abnormality at the beginning and not anymore few hours later. And so we were thinking at that time of some sort of venous engorgement, but again, it's a thought that was corroborated again later on by the venous thrombosis. So for some reason, a severe engorgement resolved luckily in this baby. I think when we asked to use for clinical reason ultrasound, sometimes we're very worried about some uncertainties. I mean, in terms of priority in my mind, congenital CMV infection can be easily diagnosed because of that appearance, the lenticulostriatal vasculopathy. This is a term baby with a known congenital disease. This is not the point. This is not the point either, because the baby had performed MRI, and that with that kind of appearance, we know we can't find anything, just wider perivascular spaces with so evident ventriculostriatal appearance in terms of echogenicity. The problem is that when we have to decide if we need or not to need to treat the baby, and we need to name what does it mean a symptomatic CMV infected newborn baby, I think it's very difficult, because even on the very important journals, we still see some sort of suggestion like you should base your decision also on central nervous system involvement and periventricular echogenicity to decide if the baby will receive or not the drug. So I think it's very difficult, especially on that kind of appearance when it's the only abnormality, and when in our mind we see an abnormality on MR, we don't see on ultrasound, we don't see on MR, so it's difficult for us to go in this direction, and it's very important for the future for the baby to be treated or not. So when we compare the two techniques, of course, for term babies, much easier and more informative to perform an MRI compared with the ultrasound, but we're using, as I've been showing you, and when we move to a preterm, extreme preterm, ultrasound is too good, it's too useful, it's too useful. You saw also the papers quoted by Roger before. IVH is an important issue to be diagnosed. And with this picture, you can see all the grades of IVH. You see the subependymal, well, we were naming that because we didn't know it was germinal matrix, the intraventricular, and also the venous infarction in that baby. So grading the severity of disease with ultrasound, I think 99% of people in this room are familiar with this kind of images in which we have grade 1, grade 2, grade 3, and not anymore grade 4, such as used to be called up to many years ago, but post for the periventricular infarction. And the beginning we were naming the grade 1, grade 2 based on a CT study from Papil, and only after a few years, thanks to Joe Volpi, we also decided to grade on the amount of blood inside the ventricles, and also to move from pathogenesis that was not an extension but to a parenchymal infarction. So it's also very important to see where is the venous infarction. You see this baby in our unit that's corresponding to caudate vein infection. You can have infarction also with very tiny hemorrhage. and also this much more worrying venous infarction in this area of the brain, together with an hemorrhage, a more important hemorrhage, the terminal vein was infarcted. I think this is the nicest paper from Jeroen Duding, showing that the location and the extension of the venous infarction is very important for the outcome. Of course, with MRI, it's much more simpler to have a gestaltic impression and feeling of the lesion and the loss of fiber tract corticospinal evidence of the problem and the difference in between the two sides. But when we move to a different kind of complication, like a grade 3, of course, the main problem is post-hemorrhagic hydrocephalus. Post-hemorrhagic hydrocephalus, so ventricular dilatation, is very worrying. And this paper from Malcolm Levine of nearly 40 years ago, so when we introduce measuring in some exams, is always reassuring, is still very highly quoted. Even nowadays, we're using in our unit the system that was created at that time, according with the different gestational age and the centiles. Even recently, in this very important and difficult study, because it took quite a few years before to see to be seen on the journal, they were using the Levine system, the Davis system, in which you measure the diameter of a ventricle, and they were using a low threshold, saying that the 97th centile only and 6 millimeters, or a higher threshold and a wider diameter as well for the Davis system, to put a catheter to treat the post-hemorrhagic hydrocephalus. It seems that using that higher threshold, it was causing less use of VP shunts, but this is maybe not so reassuring, because fortunately, I think this is a very important finding from the same group, in a sub-nested group of babies, that using the lower threshold is probably better, because it's saving more amount of parenchyma in the brain. But when we develop such a severe disease like an IVH, we have even other problems. We know we may have cerebellar atrophy, and this is the study from Andy Whitelow. Let me show what is going on. This is an unfortunate baby that came to our unit using an external device with a tricky way not to get babies infected. We have very few infection. And you see atrophy on the cerebellum. From the original hospital, the MRI was showing 8 weeks before quite a significant amount of blood around the cerebellum. So what does it mean for the cerebellum? Well, there is again a very nice paper showing that on these premature babies you may have disruption of a cerebellar development, and this is a potential complication of prematurity. But if we look at the data, 70% of them had post-hemorrhagic hydrocephalus. And the theory behind is that the external granular layer can be damaged, and we still don't know how important it is, even because it's carry on in producing the cells. It's pretty intriguing, this post-mortem finding in one of our unlucky baby, in which you do see the amount of blood and some pieces of external granular layer by this floating blood around the cerebellum as well. But the problem can be further compounded by an adding problem. So you may have atrophy for some reason, I don't know exactly which ones, but you may have as well some cerebellar lesion in the brain. And we do see, that we can observe the blood going there as well. So the cerebellar lesions may affect the brain of these babies, and it's very important to diagnose them and to know how to diagnose them. is not so uncommon to have IVH and cerebellar lesion. Probably nowadays we're facing less cerebellar lesion compared to a few years ago. But we wish to have an idea how good we are in diagnosing the cerebellar lesion using the anterior fontanelle and the mastoid fontanelle compared to the gold standard to see the blood, that is MRI. So these are the pictures we can obtain from the mastoid fontanelle, and we can obtain different cuts as well, going up to the tip of the cerebellum as well. And we already knew that using mastoid fontanelle, we may have improved the quality in assessing lesions that may have been escaping from the normal fontanelle. You see in this baby, you can't see anything as well. The gold standard is the iron in the cerebellum. You see superior to gradient echo standard diagnose minor hemorrhage, so it's much better susceptibility weighted imaging to identify the iron. And we managed to see that the mastoid fontanelle increased the accuracy in detecting limited cerebellar hemorrhage more than 5 millimeters. But again, the minor hemorrhage were really impossible to be observed from any window with ultrasound as well. Is it important? Recently, the Dutch bigger group joined the data from Italy and showing that there is a risk of abnormal outcome increase with increasing size of cerebellar hemorrhage, and especially when we looked at the group of babies without supratentorial lesion, so just isolated cerebellar lesion. It is important to grade low degree of IVH. I don't know the answer, but it is difficult for sure. Much more difficult to say this is grade 1 compared to grade 2 than not to say grade 1 to venous infarction or grade 3. And we managed to highlight that some minor form of a hemorrhage are escaping from the diagnosis with ultrasound because they can be picked up by susceptibility weighted imaging. And quite few, despite the population was not so big, could be really seen only with SWI at MRI. Again, is it important for the follow-up? We don't know. We have many papers showing that grade 1 and grade 2 are not so important to predict prognosis, but again, there are worrying studies like this one in which a huge population of babies with grade 1 and grade 2, apart from the bias of having missed few babies, seems to be significantly related to developmental delay and cerebral palsy too. So we wish to trigger even more and to dig in this direction to compare the white matter around the ventricles in case of very mild germinal matrix hemorrhage in a population that arbitrarily we divided with a cutoff for 29 weeks gestation. And we could observe different kind of findings in babies below 29 weeks and in babies above 29 weeks, in which you could see that above 29 weeks you have fractional isotropy, that is a measurement of the white matter complexity, looked impaired in these areas. And we don't know why, but a potential explanation is that the white matter is potentially influenced by inflammation from the hemosiderin, such as some post-mortem studies are highlighting. Vice versa, on the 29-weeker, fractional isotropy wasn't affected, but radial diffusivity, axial diffusivity, medial diffusivity was increased, like showing that there was a direct insult or like lack of fibers there. And it's very intriguing to know that there are studies like this very interesting group in Sweden with David Ley at the head of the group, showing on experimental animals that the blood is going in the white matter after an IVH through the ependyma. We have very small signal in the subnested population that this problem can be even related to the outcome. We are completing the study now. But what is very important in our opinion is that we may face that the iron and the hemosiderin can last for quite a long time in the brain. You see the baby has 2 years. So we went even more looking at quantitative susceptibility mapping, trying to see if there was differences among babies normal with mild IVH and severe IVH. And I think it's interesting to note that some area of the brain, like centrum semiovale, with a very severe IVH, was showing a high degree of significance with persistency of the hemosiderin signal in that area. Of course, these are speculative thoughts. The problem is much more complex, and we shouldn't forget the great contribute from Joe Volpe saying that is a mixture of a problem. So simply diagnosis a brain lesion doesn't mean always a lot for the future of a baby. The cerebellum is important, but the white matter is very important for the future of a baby. And when we move to ultrasound and white matter, we need to have a flashback because it was very important to be so rigorous in assessing the cogenicity of these babies, because we were extremely worried of cystic PVL 20 years ago. And thanks to Linda, we were classifying periventricular echo densities in persisting grade 1, persisting with this very tiny cyst, frontoparietal cyst, persisting more extensive and very extensive cystic lesion. Fortunately, the incidence of such bad disease has dropped dramatically down, and so we do see very little PVL. But another problem is then if you should suggest a guideline when to screen babies at which gestational age, because I think still some PVL are following an eventable clinical course in not so very tiny babies with a 32, 33 weekers, like this one in our unit. You can see the ultrasound. So there are answers that we have to be looking at. Even Linda, you see, she didn't suggest which kind of gestational age to put as cutoff, but of course it's very important to perform serial scans in these babies even nowadays, especially if they've been sick with that kind of problem. If we move to MRI, we know, I still remember the emotion to see these tiny abnormalities in the white matter many, many years ago. We believe that they probably represent the mildest form of old PVL, because sometimes they coexist with tiny cysts on MRI as well. And despite cystic PVL is dropping very down up to below 2%, punctate lesions are extremely common in babies. Can we see on ultrasound? I think we can rarely see, especially if they are quite well represented on MRI, like in this baby that presented a mild diplegia 30 weeks. It's impossible to see very tiny spots on MRI on ultrasound, like in these babies that was scanned very correctly through the days of his life. There are few papers trying to say how important it is to have a punctate white matter lesion for the future of the babies. I do agree that this is not the highest risk for cerebral injury as a sort of potential landmark of brain insult. And I agree that if you are more than 20, the clinical significance is definitely higher. So I'm concluding my presentation, trying to tell what we're trying to do about being supportive of good science on ultrasound. This is an initiative, European Ultrasound Brain Group, that has already done a few editions 6 or 7, if I remember well. The first one is here, that was in Madrid. You see the people in Madrid. You see Sandra Hosch, you see Adelina that couldn't be here chairing the session. And a special thank to Paul Govard, that is the inspiring mind of this group of lovers of neuroimaging, training a tiny group of young performers in ultrasound. And I have to admit that it's a bit too late to disclose my real conflict of interest versus neuroimaging, but we're fully aware that even nowadays that we're more confident to make diagnosis of very minor degrees of brain lesion. This is far from me very exhaustive in telling how the baby will be